this evening. I'm sure you're not going to regret it because this is going to be the best session you've attended today. I promise you that. You will not only listen to expert conversations around diagnostics, but you are also going to have drinks and you are going to have a scrumptious dinner. So just sit back, relax, and enjoy the time here with us. My name is Ntombi Sigwebela. I'm the Regional Director for FIND. I am based in South Africa, in Johannesburg, and I'm very excited to be here at the CPHIA conference in Zambia. And I'd like to thank the Zambian people for their hospitality. We have appreciated the heat and have baked really well in it. I'm going to be the moderator for this event today. I'm also going to be moderating the last session of the day, which is really going to be exciting because we are going to have dinner afterwards and we're going to network. We have planned ahead for tonight an engaging fireside chat with experts in the diagnostic world who come from different key stakeholders that FIND and other global partners work with. The agenda is on the QR code that you see there. Those who haven't seen it, through the LinkedIn or other online service that you use to book to come here. And on that same agenda, you will find the biographies of all the speakers today. So during the proceedings of the session, we will not be going through the biographies in extensively. Please read through them. We're going to have 6 conversations or sessions. All of them will be centered around key diagnostic areas of importance, and the big issue being, or big question, being the WHA announcement in May of this year around diagnostic resolution. I'm sure everyone in this room is aware of that, where 15 resolutions were taken by member states, and leading in that resolution were African countries, but we will talk about that much later on today. And this is a conversation that continues from that. And those who attended at that time would remember that, again, FIND had a similar session, Diagnostic Day, which lasted the whole day. In addition, tonight we are going to have some exciting news that FIND and partners are going to be announcing. So I urge you all to stay until the end. If you like gossip, you better stay until the very end. Then you'll be able to hear what good news we've got for the global community around diagnostics. We are also going to have speakers representing all the key partners. We have speakers coming from Africa CDC, WHO AFRO, the Ministries of Health in Zambia, in Kenya, in Uganda. We have International Pandemic Preparedness Secretariat, Diagnostic Equity Forum representing communities. We have Davy, and we have our key partner, Rwanda Biomedical Center. We have divided the sessions into discussions around sustainable, resilient health systems, which is the first session that we're going to go through, and then improving pandemic preparedness, building health systems for people, not for diseases, disease elimination, showcasing new generation of diagnostic tools which are displayed on the table here. These will be explained to you, very exciting. And we'll end with a discussion around, now that the diagnostic resolution has been taken, what are the next steps? What is it that we need to do? What does it mean for Africa? So that's the lineup for this evening. Without wasting too much time, I'm going to call upon Daniel Bausch, who is our senior advisor at FIND. He's going
consider not only for the pandemic, but of course in the field I work in, but we're all so really trying to make sure that diagnostics is integrated in the very low levels and of course we're fortunate to have a very experienced speakers who have worked years to try to do that. Take my do some introductions. The assistant director of the lab, Zambia, and lastly but not least, Dr. Fongwen, who's the diagnostics access coordinator for applicants in the city based in Paris. So thanks to all of you for being with us here tonight. We've asked, we only have a short time, of course, we only have just 2 hours for us, right? Yeah, so we have, I think, 15, 20 minutes, and so it's going to be very brief, but each of our panelists we did brief 5 minutes. Maybe the one situation where we have the time. I'm sure I can help with a few questions. Over to you.
Thank you so much, and good evening to everybody. It's a pleasure for us to join you in this conversation around diagnostics and how that relates to sustainable systems. So I am with the Emergency Preparedness and Response Program based at the and the work that we do is really to support countries in the region, kind of 47 member states in the African region, to support them to build their capacities for response to emergencies and to prepare for emergencies. So a lot of what we do is based on resilient systems. If we're not able to rapidly detect identify vulnerable emergencies, then that affects mortality and morbidity. So diagnostics is very much a pivotal central aspect of the work that we do in emergency response. Just to put into context how this relates to resilient systems, we are all aware of the declarations passed, the standard declaration building primary health care, the 2030 agenda for universal health care coverage, the sustainable development goals. There is a linkage there. Diagnostics being crucial to ensuring high quality, all-encompassing, integrated primary health care health services for everyone, everywhere, wherever we are. And at WHO, we gained valuable insights from past outbreaks. We all remember the 2014 Ebola outbreak, and the realization at that time that countries just didn't have the capacities to be able to detect the virus, to be able to respond quickly, and that was the
All three of you. Ntombi, I think we have 5 minutes, so 2 questions. So as you've been speaking, questions, most of them occur to me are very easy questions, but then I think we go one hard question. And so, for example, in the gene, you can give me one question. Yes.
That's why you are able to diagnostics diagnosis that is done at the peripheral level. So
now can actually produce samples for several things. You have to results and different samples. There's a lot of math that needs to be done to understand around something, for example, so if you're not certified, you have to have this is a very
I'm now going to call upon my colleague, Dr. Emmanuel, who's the Director for Pandemic Preparedness at MIND. He's going to be chatting to Ms. Charlotte Baker, who's the Head of Programs.
it's going to be like a fireside chat. Start the show with Charlotte. So, Charlotte works with the IPPS. I'd like you to tell us a little bit about the IPPS, and then go on to tell us a little bit about the Conjuring Mission.
Yeah, thanks very much, Emmanuel, and a real privilege to be here among such esteemed panelists today to talk about this really important topic. So the IPPS stands for the International Pandemic Preparedness Secretariat. We are a time-limited, very small team set up to essentially facilitate the 100 Days mission for pandemic preparedness. And I think that part of my role at IPPS as Deputy Head is to run our strategic engagement and communications. And we clearly have a bit more to do on that element based on the show of hands in the room today. But the 100 Days mission essentially was conceived originally by the G7, but it's not just rooted in the G7 anymore. And the aim was to really enshrine the learnings from COVID-19 and think if we'd had products available on a more condensed timeline, more quickly, how differently could the trajectory of the pandemic have looked? How many lives and livelihoods could we have saved? And the essential fundamental aim of the 100 Days mission is to make mission regimen of diagnostics, therapeutics and vaccines available within 100 days of a pandemic threat being identified. The 100 days can be a little bit of a sort of red herring because, I think if it was still 150 or even 200 days, we'd be absolutely delighted on lots of the metrics that we're using. But the idea is all about condensing timelines to product availability with equity and access absolutely fundamental principles enshrined within that. So at IPPS, our job is to facilitate the 100 Days mission in whatever way that we can. Some of you may have heard of the 100 Days mission for vaccines, which is probably the best known part of this initiative. The 100 Days mission for vaccines is owned by CEPI.
yeah, the breaking news that was referred to is that we're really delighted to launch today at this event on our new report, which we are co-publishing with Find, which is called Making the Exceptional Routine, Embedding Diagnostic Best Practice to Improve Pandemic Preparedness. And one of the major tenets of the 100 Days Mission is actually that during COVID we saw lots of exceptional collaboration. We saw lots of exceptional speed. We saw lots of systems kicking into gear in a way that we hadn't seen before. And we also saw, we have to say, huge inequities in access. And what this report aims to really hone in on is some critical enablers for actually embedding that best practice now, ahead of time, in between pandemics, and also critically making it useful, not just for pandemics, but also for endemic disease. And I think that's really at the heart of a lot of what we talk about when we're thinking about pandemic preparedness, is that, governments are dealing all the time, as we heard from our previous speakers, with lots of competing public health challenges, and actually having infrastructure set up that's only going to be there for a pandemic time is not going to be seen as a good investment, and arguably isn't a good investment. Actually, what we set out in the report is that there are some critical things that you can implement in between pandemics that help with monitoring for endemic disease and testing for that disease, as well as then being able to pivot and test for pathogens of pandemic potential, or when your pandemic has come, the specific pathogen for that pandemic. And so we have these three critical enablers that are focused on in the report. One is the potential impact of multiplex diagnostics, so turning the question from, does the patient have this, to what does the patient have? Digitally connected diagnostics, and so looking at the idea of plugging in the results of testing into wider surveillance and health systems, and then looking at test and treat and how you embed test and treat best practice, taking the learnings that we had from COVID-19 as well. And I think it's been a fantastic journey working with the diagnostic subgroup, including Find, to develop this report today. And I think Emmanuel is maybe going to say a bit more about the enablers and how those work in real life.
Yeah, so the enablers that actually mentioned as well. First is multiplexing, so the idea that can we develop tests that can diagnose pan-pathogen as part of pan-pathogen approach or multi-disease approach, so really going beyond the current approaches where you do a test for one disease. So can you develop an approach where you can have tests that can be deployed nearer to the patient, that can unpack what the real diagnosis is. The other real idea is around digitally connected diagnostics. So can we think about new tests perhaps that can be digitally connected? So we have, for instance, GeneXpert that has the capability for digital interconnectivity, and then you can move data from the patient side into the surveillance system. So these were clear challenges that we saw during COVID, that even when you ran a test, the time from when you did the test to when the patient got the test, to when the surveillance system got the test, to when the patient got treated, those gaps still exist when we manage patients. So how do you begin to think about changing the way diagnostics are developed to begin to get that benefit? The other piece is really around test and treat. So I mean, this is a contentious one, because even about COVID, people were tested, but there was no access to treatment in the African context. So can we now generally begin to think about how, when you develop tests, can you improve access to treatment? But the absence of treatment still should not negate the importance in ensuring that the importance in making access to testing a priority. And I think this is an issue that we've talked about Charlotte a lot, maybe reflecting a little bit about that, particularly that piece of test and treat, an interest of the partners in the room, WHO, Africa, CDC, and maybe we can talk a little bit about that, and maybe tie that into the listening exercises that were done, so that and maybe just
Yeah, thank you. I thought the comment after the previous speakers about we're all friends was quite revealing, actually, because we see a lot of siloed approaches in global health, actually, where sometimes it feels like the tools are kind of competing with each other in some ways. Vaccines, diagnostics, and therapeutics. And at the 100 lack of availability of rapid tests was a barrier to accessing treatment. And actually now it's a case of thinking, okay, so what do we do with those learnings? Obviously, access to those treatments is absolutely fundamental, and actually in the 100 Days Mission we're launching a new therapeutics roadmap next year, which will also look at that particular issue. But I think it's also about seeing this as a nexus that's really important in terms of embedding the access to diagnostics, but crucially also not just seeing it as a means to getting treatment, because there's a really important imperative that we learned in HIV about the right to know one's status and the right to have that public health information and then be able to take action that you yourself choose to take in that context. And as you were saying, we held a series of regional listening exercises over the summer, and this was part of our attempts to understand better how the 100 Days Mission could be implemented across the world. And so we held 4 regional listening exercises in Southeast Asia, in Latin America, and in the Caribbean, and also in West and East Africa. And in the African listening exercises, this issue of testing trees and embedding those approaches came up, particularly with regards to equity, and also in terms of the delays in access to some of the rapid tests that were available during COVID, particularly things around guideline development and those kind of normative approaches. That was something that came up in those listening exercises as kind of a way of, as one of the barriers to implementation. And we also heard about the challenges actually around regulatory harmonisation, which is really interesting to hear the previous conversation, because that's basically exactly the feedback that we got from researchers, clinicians and others from listening exercises, was that actually the lack of standardised approaches to diagnostic regulation was a major difficulty in terms of putting in place testing strategies. And then a couple of the other issues that we heard raised was around the idea of felt like testing was a reactive. That you generate a test, you get the test up together in response to a pandemic. There was a sense that actually stakeholders really wanted to move to a preventative approach with testing that was plugged into surveillance, where it seems that everyday testing. And I think this is one of the challenges perhaps with funding diagnostics as well, is the diagnostic system is something that you grab and go when you're in a crisis and you really need to have your tests all of a sudden. And actually it's about saying, particularly to funders, to industry, this is an investment in health overall. This is not just something you're grabbing out of emergency. That came out really strongly in those listening exercises. And then finally, one thing I wanted to highlight is the issue of trust, actually. And some of the participants in those listening exercises highlighted that there was a certain level of fear in some communities about what a positive test result could mean. Could a positive COVID test result mean that I actually have to stay home, that I can't go around the building, and that I can't feed my family next week? And I think that was a really interesting bit of feedback to hear, because it does actually really highlight the importance potentially of self-testing to allow people to take the tests in the privacy of their own home. We know the lessons of HIV in this area and how actually they can really accelerate public health action. And it was really interesting to hear that come through so strongly in the cases here. So COVID in particular. Emmanuel, I think what mentioned earlier, there are some places where this works to help with Fiji and Russia, so we definitely would want people to move to a certain type of public health action. But it was a really constructive series, and those exercises can be found on our IPPS website if anyone would like to read the summary.
to operate in space where we can connect different topics together and having diagnostic sessions. So some of the for example, finding a problem science expert group, science representatives, expert other organisations and academics are involved. I think those programs show all those different perspectives of the group to come together and watch the iteration come actually shows real value for different benefits. I guess that sounds like an obvious point, but I work over the growth and headspace for a very short time, and the siloed approach has failed to raise me. Actually, and I do always say the seeing what we're doing, yes, it is organising, and actually really useful partnerships together around this shared goal, and that's what we're trying to sort of say, running around the dinner, and in fact, come up with a have a chat where it grows, because what we thought was maybe to make partnerships and connect on those dots.
The diagnostic.
Oh, yeah. They replied but it's fine.
of time, that means that we are spending twice the amount of money we are spending to treat diseases in what I call the firefighting system. And when you look at that firefighting system, it is unsustainable because it keeps growing. So we sat down and asked ourselves then, how do we finance a healthcare system that is sustainable to the end at some point by, one, allowing our money to do more, the little that we have, how does it do more? Two, by shielding or averting diseases, and this is where the primary healthcare level became important. And four, that by reorganizing the healthcare system in a way that it becomes structured. You know, market failure occurred within the healthcare system in Kenya, and for a long time, the public system did not respond to the needs of the country. And that also brought about the private sector increase. Now, with the private sector that is also covering around 44% of the utilization, then any healthcare architecture must take into consideration that the Kenyans, 44% of them seek care of the primary health, the public facilities. So the primary health care level is ideally with two main drivers. One is the community health level. Kenya has rolled the largest community health promoters program in Africa so far, with 100,000 community health promoters paid by government. Diseases progress. Thanks.
Now that you mentioned diagnostics, and if I don't ask you a diagnostics question, I do not have a paycheck by the time I'm sitting down. So the first thing you talked about an issue that's also important, the current reform, optimizing diagnostic systems. How are you factoring that into the current reform?
So one of the key problems we have within the African economies is not even Kenya, because I've worked in this region in finance and architecture for quite some time. And the issue of diagnostics,
my big problem that we have, and it's a problem that all countries have, relates to harmonization and federalization. So you find that these countries of ours have small populations, so the demand is a little bit low to make any business case for, sound diagnostic investments, not only by government but also by the private sector. And why this happens is because we are too fragmented. So you find that we have different diagnostic equipment that use different reagents, and when you are hooked into one, you cannot pull your demand. Now, if you cannot pull your demand, then it remains expensive to actually diagnose, because the things when you access your reagents, they are very expensive.
So it becomes a challenge. One of the things we are thinking about, and this is what the direction we want to go, is to think about how do we harmonize our diagnostic capacities across most of the public facilities, and then we negotiate for better pricing of the reagents because, the equipment can be cheaper. And this is how many of our, past mistakes have been done. So when we look at the equipment, some equipment are far cheaper, but the reagents are very expensive. So when you look at the long run, you are, losing as a country. So the most important thing we are thinking on is that our diagnostic abilities are not well founded in doing any business case, and therefore we cannot be able to
economies of scale is difficult to achieve, and then that again limits our ability to get a right price. Now, for the demand of this lab, for instance, we are very strongly motivated that hub and spoke models should be able to work. This is where we have well-placed, well-equipped laboratories that are serving some other small hubs. Spokes around it. And you will be assured that the lab has enough capacity to do what is needed to be done. And you will also be able to mix this with innovation of digitalization so that you are able to lay back the results in time. So you will see that this kind of a model will be piloted, but not under the current systems that are there to do the diagnostics. We are largely in the buying as a government, or we are raising them. Now, what happens is that these models are motivating, so the lease have services. So it motivates the providers to actually want to be down several times so that they add value. But when we have clear fee-for-service based kind of financing, where placement is done in public facilities with a agreed value, and then the equipment is supposed to function, and then we'll be able to deal with the social insurance, for instance, with a certain value that is fixed. So that makes sure that the owner of the equipment is happy with it. Because if it doesn't function, then you will not provide a service and you will not be paid. So when we offer the funding mechanism, we believe that it will incentivize provision of service rather than timid business, regardless of whether a service is available or not. And that is what is happening most of with our past funding mechanism for managed equipment services. So this was there's a question in the room. There's a half of the basket, there's a mic, there's another hand. First, to commend the government of Kenya for bringing innovation, because with the tiered approach that we see more around at the end of the tunnel, especially in terms of diagnostics, diagnostics, and even prevention. The question to you is, to human-centric science citizen, we notice that some diseases, the woman will go through surgery and then the sample needs to be transported to be taken through to the nearest diagnostic center. And thinking about maximizing efficiency in sample aggregation for effective diagnostics, of course, and for access to treatment, what do you do to maximize that hub-and-spoke model where the woman doesn't have to travel with the sample itself, but we can be able to get the aggregation of the sample to the results of the woman and the facility? Thank you. The second question is, you can answer that one.
talk about accommodation, the next discussion starts in what we call MCD, the other pieces. So when we approach this financing sector, that we have been ideally. So we usually have not substituted because the response of people require more. So we look at the political indicators that large increase the human resources to be able to put. However, we also have the activity is possible. And the top is where we invest upper for prevention. And this should be kept in mind. So if you look at our approach, we are getting the customers to line and connect to actually invest finance for needs anyway. And when you look at the standard of the community, the extra is not money at all, and then something else. So we need to follow the organization as not some of but we want to factor in that if you want to know what these forms are, then we should work out a lot of capacity. And don't say that the money that but we are not getting it. So when you look at the most resources, you see the side of the so we have never been able to talk about substitution. Because the general never has because we all so they should actually how much for something and chiefly I want the fact that when you have a lot of then you massively go to very efficient times and some of them
is why you see also have another which involves force for facility and financing investment. Why that was important because because the money went to public health facility. That money went to source of money of the county. And there was no very clear money from some people. So the county of course have been optimizing so the huge shift in the money that most of the facility that is public should actually use services to the facility. So if there is an increase in the service and the service is provided and paid, then what is supposed to be paid for that service,
really think that we must, on purpose, change. And why we need to change, again, is because the clinical work and the whole of this health agenda, which is fantastic, is only understood very well by the political class, for instance, when they get sick themselves. And you look at again our countries in Africa, they have made good progress when the political class have died of serious diseases. They are suffering from them, and I mean you cannot start praying that our agenda strategy for pushing our agenda is these guys to get sick. So we must get a better way. And I do believe that the key problem lies in our inability to communicate what seems like a hard topic to laymen, and also show them why it is important to do what is important, what you want to do, and align the interests. Because there is an incentive compatibility criteria for a politician. For instance, is to know that my people will know I am the one who have done it, and they will be happy with me, and they will elect me next time. So we say that a rational consumer in a market, if you want to see somebody who is rational in a market, you only observe two things. One is that they are able to rank their preference. You should rank. Apple is better than banana, than orange. You should be able to do that. The politician is also doing that. He's ranking. My first employer is the people. So anything that makes the people, whether it's real or not, feel happy that I am doing it, that's what I will do. The second thing is, as you rank, you observe the axiom of non-satiation. More is better than less. So when you see a politician ranking that my people being happy is number one, they have not erred. They have done what you are doing also. So we must align our interest to the interest of the political class. And in doing that, we must pitch our agenda in a very high level. So this is what we did. And as we began with the primary healthcare strategy, which we did quite a good primary healthcare strategy, but we decided, instead of making it lie there, we started, interpersonal engagement, bilateral engagement, to explain to the political class why it is important to push services closer to the people. Now, as you do that, give the things that make them feel bad, because that is what you must check what makes them feel pain. It's not like many people got treated. That's not their problem. Their problem is to know that people, even if they got treated, they know that they are the ones who made them get treated. Because that's what brings votes. The other one, they don't care. Now, we started also checking, why is it that we are constructing facilities every time? Like hospital number A commissioned by the president of Kenya, and there are cameras full there and they are very happy. You see, why there are cameras and very happy is because that's a political agenda, right? But inside the facility, you might find there is nobody. There is no human resource. There is no medicine. So if the people could know that it is important to have a facility that is working than the one that is not working, then they will start going the other way. So we piloted this agenda once in a county called Takah, and we had a good team of good people who are broadcasting what a politician has done currently. Or invest in the software of a facility. So if you build a maternity, they don't broadcast. If you bring commodities, they broadcast. So what we saw is that the political class started bringing things, not because they want to take them actually, but because they want it to be broadcasted. Now you can see that we must look at people, appreciate that the way a medical doctor went to school to study on how do I address disease A, how do I diagnose disease B. There is someone who went to school to study how to communicate. How are we bringing these people into our system? Now, if you have that kind of people, that is how we will start having other qualifications and specialists coming in to guide us. Like we used to, when I started working with the USAID, my title was Efficiency and Effectiveness Advisor. People used to wonder what kind of work is that, and why is it important? More so in an HIV program, because there was so much money that the problem was how to spend it, not whether spending was the issue. The pipe was not moving. You see, 15 years down the line, there is no money there. Now they are understanding why efficiency and effectiveness was important. So what I'm saying here is that the healthcare sector must open up to learn and bring other professions who can, catalyze our achievements, and we are able to move closer to where we want all of us to go. When I start talking about money, I can talk the whole day. More so for help, because I do it for a passion. So thank you very much.
Thank you, Dan. And he's here for dinner, so the non-Kenyans can feel free to approach him. And the Kenyans can give feedback directly to him. Thank you, Dan.
Thank you very much, Angela and Daniel, for this interesting discussion on the Kenyan PhD generation. We'll now move on to diagnostics and disease elimination, and I'd like to call upon my colleague, Professor Joseph Ndungu, the Executive Director for FIND in Kenya, but now we're moving countries to Uganda to talk to Professor Charles Wamboga, who's the Head National Coordinator in Uganda. I'll hand over to Joseph. Can you start?
Thank you very much, Ntombi. We're going to shift gears now and talk about neglected tropical diseases, and who best to engage in this discussion other than Dr. Charles Wamboga, who is the head of the Sleeping Sickness Program in Uganda. Dr. Wamboga is a medical doctor with MScs in clinical epidemiology and statistics. And before, he has also worked as a medical officer and a regional coordinator for sleeping sickness in various parts of Uganda. At the present time, he is also, in addition to control and regulation of sleeping sickness, involved in control of other NTVs and has been involved in clinical research on sleeping sickness for more than 20 years. So, Dr. Wamboga, thank you very much for being to be part of this discussion. And the way we are going to do it is just give a story, and if you feel you'd like to raise a question or make a comment, please feel free to interject. Although at some points, we will also be posing to ask questions. But before we pass over to Wamboga, just a small introduction about NTBs. NTBs are categorized into two groups based on the manner in which they are controlled. One of the groups, what the approach that is used in the control is once it is identified in a region, the population is treated. That is called mass drug administration. The other category is one where, in order to control it, you need to identify an infected individual and put that individual on treatment. But as we move the major drug elimination of these NCDs, we are seeing a convergence in that even those diseases that are controlled through mass drug administration are also getting in the elimination phase to a stage where we need tools that will identify the individual and put the individual into treatment. Having said that, we now go back to sleeping sickness, and this also is going to bring out what diagnostics can do in control and elimination programs. So Dr. Wamboga, you have worked on sleeping sickness for many years in Uganda. Tell us how it was when sleeping sickness was classified as one of the most key prevalent diseases. Since we are still secondly, we have had a number of refugees coming from South Sudan into the country. And you will know that the endemic countries of the civil sickness. And actually, the last case that we recognized was actually someone from South Sudan, even the one of our refugees students.
So before we go to what's next, do you have any comments, observations, or questions from the audience?
Charles, you talk about neighboring countries, and this brings in the importance of, if we are talking about disease elimination, there has to be a regional approach, not as activities may be country focused. There is insecurity in 2016 in South Sudan, when that resulted in millions of refugees coming from regions that have simple sickness. In this area where they have been successful. How this simple sickness rate, and what do you do to address that situation? Yes, sir. Because they are coming from an area which is endemic, simple sickness, and so we got sickness nights, as you said, and the first thing we did was I had a discussion with the client and positively, and I think that's why I would like your flexibility, because I remember we had a discussion over 2 days, and our biggest problem was how do we address this? People know that you have to have activities to test that. So with your flexibility, first of all, we were able to do interventions in the respective settlements, but at the same time, we initiated a cross-boundary collaboration between Uganda and South Sudan, where we have regular meetings, where we even enlist our partners to try and hold the fire from where it is coordinating and extend activities in South Sudan. My task is not to initiate a battle there. So I would like to say that we appreciate your flexibility, and because at least we are able to address that issue.
So now, Charles, considering where you are, no cases since 2020, you're still using the same tools. You know that they are not 100% specific, they are not 100% sensitive. What risks do you see going forward to sustain the elimination status?
Yes, the risks are there because, as you said, and as we all know, the tools are not 100% perfect. They have issues of sensitivity and specificity. And if you see where we are coming from and where we are going, we now have very few cases. Meaning that getting even those small number of cases that would be propagating the infection is very, very important for us. So we want to have a test that is able to pick those remaining few cases so that we remove the reservoir from the community. But as we have been declared to have eliminated the disease as a public health problem, it is important for us to continue doing surveillance, and this is what we are doing. But preferably with better tools. And if probably we even get improve their performance, so that probably if the specificity is 95%, let it go higher so that we are able to pick the last remaining cases there for us to sustain the gains that we have made over the years in as far as eliminating this disease is concerned. So that's our appeal. And then the second one is probably not rely on only one test. You could probably try to look for another tests or any other tests that would support the post-validation process, because we are now in the post-validation process, and yet we are still using tools that were discovered roughly 10 or so many years back. So I would like to, those are the points I would like to say moving forward.
That's great, Charles. I think to a certain extent you might end up being a victim of your own success, because what will happen is that when you have no cases being reported, you have eliminated the disease as a public health problem. Eliminating as a public health problem is not total elimination, because it is not zero transmission, meaning that you still have to continue surveillance. You have talked about the cross-border risks that are there. Yet this is the time when the funding situation could deteriorate, because the risk is lower and the neglect becomes even higher. How do you foresee sustainability of the efforts that you have already made going forward?
Yes, and as you mentioned, when the problem goes down, even the resources, people are not willing to put in more resources, because they say, so where do you put in why should you put in resources where the problem has gone down? So the good thing is, with some of the tests that are available, they can be integrated within the healthcare system, even at the lowest level, because they are easy to read. I think that's one thing that needs to be done. And then the other thing is to be open with our governments to own it up, because probably people have been supporting us for a long time, and now that the problem has reduced, they will say, can you please own it up? So that is how I would like to look at it. But of course, we are still welcome. We expect we may not have a lot of resources for such an involvement. Probably the government partners and others can come in and support us in the research and development. And then for the governments, we would convince them to start taking on some of these activities, like integrating some of these tools within the healthcare delivery system for sustainability.
That's great. Thank you very much, Charles. I wish you all the very best. Just for your information, the program that Charles is describing, FIDE has been a partner among many that have been driving this, not only in Uganda, but a number of countries. What he just said about the response in South Sudan has been quite good. The last year or so, there has been no case of sleeping sickness being reported anywhere near the border with Uganda, which increases the confidence. And at the same time, these lessons are being moved on to other neglected diseases. And they reflect what diagnostics can do, especially when we are talking about elimination of diseases like this. Now I'll open it again for any comments or questions from the audience. Daniel.
I don't know if I need a mic, but just for online. Yeah, thanks for that. Really, really interesting. I'm just wondering, you talked about kind of the programmatic part of trying to polish this disease off, at least in Uganda, and then the need for funding, of course. But if we can get back to my question a little bit on the technologies, do you in the diagnostics, do you feel like you have the tools that you need, or is there R&D that needs to be done to get you the right tools to really finish this off?
So it's back to you, Charles, about tools. You think that you need additional tools or better tools?
Yes, thank you so much for that question. I mentioned that we need an improvement in the existing tools to improve their sensitivity and specificity. But again, we need we need other tools, because you cannot just rely on only one. So if we could have others, that would be better for us. And actually, the disease I've been describing about is the Gambiense form of sleeping sickness, which is in Western and Central African parts of the country. There is another disease, the rhodesiensis one, which is even more neglected. It actually even has no screening test. And I think that one would go into mainstream R&D to look for a screening test, because no efforts have been made to give us a screening test for that disease. So even outside the diagnostics, I won't talk about therapeutics because I know everyone here is diagnostic, but even in other areas, it has other issues. Yeah, so I've been talking about Gambiense, which is in the northwestern part of Uganda. It extends into South Sudan. It is most prevalent in the DRC, and it goes into other countries in Western and Central Africa. Thank you.
Okay, so thank you. Any other last burning comment or question? If not, let's give Charles a loud of applause for a job well done.
Thank you very much to the two professors. A round of applause for Joseph as well. Thank you. We have about 5 minutes for a stretch, bathroom break, a few more questions to the previous panelists. Then our next session is going to be the technology showcase. As you can see on this table, are displayed some new technology tools that Sanjay is going to show to us. They might look small, but it's amazing what they do. And then we will move straight on to the last session, which talks about the WHA resolution and what it means for Africa. And then it will be dinner time. So we're almost there. Just let's stretch our legs, bathroom, drinks for 5 to 10 minutes. Then we'll be back here for the last run.
And can I turn it like that?
So don't come this side, Sanjay, because you're walking space.
Give it like maybe 2 minutes just really.
Oh, okay, sorry. But I was notified you weren't. You gave us your name. But you are very welcome to
Testing. Just tell them.
Testing. Testing. 1, 2, 3. Testing. Testing. Josh, please tell us, please ask them to reduce the cost.
Okay, yeah, it's working. Okay, let's settle down. I will now call upon Dr. Sanjay Sarin. Let's settle down and it's only like 45 minutes left. Dr. Sanjay is going to take us through new technologies and all the toys that are displayed on this table here and entertain us just before we go on our definition.
I don't have guitar. Well, good evening everyone. My name is Sari. I'm the vice president of Find. It's my first time to Zambia. So I'm great to be at the conference. So more mortality. Obviously there was some glitches to start with in terms of getting a battle. Finally managed it.
Coming fresh from COVID, which probably had one clear silver lining, the central role for diagnostics. And as I think Dan said, that while we talk so much about vaccines in this conference also, there has been a lot of conversation on vaccines. So unless you diagnose, obviously you can't even develop a vaccine. And the good thing about the resolution of diagnostics was that it being the resolution of diagnostics, it puts diagnostics front and center as a great enabler to achieve universal health coverage, specifically at the primary healthcare level, which I believe has been an Achilles heel for both the developed and the developed. We have for central pressure to the L1 or the primary. As I thought the lining of the pandemic, so a slew of innovations that happen, and particularly around point of care diagnostics. So some of these technologies that we are going to talk to you about are a mix of near point of care. When I say near point of care, it still requires a laboratory setup, and it still needs to be plugged in, and it requires air conditioning and sample processing and stuff, and the true point of care, which means that it can be as close to the patient as possible. So let's start with TB, and we all know that how much of a scourge this disease has been. It still continues to be one of the leading causes of mortality across the world. And I think over the last decade, molecular diagnostics has really been central towards increasing access to diagnostics as far as TB is concerned. We're moving away gradually from the phenotypic DSPs. There used to be the time of LJ media, and then the liquid culture came in, and then I think almost 10 years ago we had the gene export from Cepheid, which kind of revolutionized diagnostics. And then came All Bio, which is an Indian company, UNAT platform, which I see a lot of instances now in Africa as well. So this was in 2020 when WHO passed a policy around the use of TrueNat, which means it can also be funded by donors like USAID and Global Fund. But despite the fact, now these technologies have been available for a while, and off late we are seeing some Korean manufacturers who are coming up with some exciting new tech. There are companies like SD Biosensor and Bioneer, and what we have here is a near point of care molecular diagnostic platform from a Korean manufacturer, SD Biosensor. And a lot of you may have heard about the SD Biosensor because they had also come up with the rapid diagnostic test for COVID-19, which was used in multiple countries. It was also WHO pre-qualified. And this is the cartridge, in many ways similar to what Cepheid has, for example. And then all of the processing happens well within this cartridge. It's like fill it, shut it, forget it, as far as the diagnosis is concerned. But still, as I said, I think this requires a laboratory setup. This requires uninterrupted power supply, requires air conditioning, requires dust-free atmosphere, and so there are challenges in terms of implementing these technologies at the L1 and at the primary healthcare levels, specifically when we are talking about the resource-constrained settings. But nevertheless, we have more choice, and as we saw during the pandemic, majority of the countries were dependent on a limited set of manufacturers for the diagnostic needs, and we clearly saw the fragility of the supply chain, and there was a massive lack of diagnostics, for the longest time, despite there being, emergency use authorizations and stuff like that. So moving on from here to something which is true point of care.
So this little device, in my hand, this is really a PCR platform. I mean, who would have thought 3 or 4 years ago that we will be able to miniaturize the technology to this extent? So this comes from a Chinese manufacturer, and and this is the chip that goes into the platform. As you can see these, and you can, once I'm done with this showcase, you can come closer and take a look at this chip. And it really has these holes, as you see, and this is where you put the sample. And this is battery operated. As you know, it's probably less than 100 grams. You can carry it in your backpack and get down into the communities, do active case finding. And it has an exciting menu. It was originally designed for COVID-19. They now have other respiratory viruses on this. They also have HPV, as we hear. And FIND has been actively engaged with this company in terms of trying to bring this technology to the fore. So from here, I moved to another device. So this is, again, PCR on a sort of a chip, I would say. Slightly larger chip. Again, it is. So we are really going down the miniaturization route here. So as you see, this is even smaller, and this is a device from a company called Veros, and it was manufactured by Sense Biomed. It has now been acquired by Sherlock. And Sherlock, as you know, is one of the companies which is deeply into CRISPR-based technologies. So this is, again, a very integrated form of a PCR device where all of the tech, reagents, etc., are preloaded onto this. You need to do some sample processing. That is basically mix the sample with the buffer. and load it right here into the sample well, and have your diagnosis basically in about 30 odd minutes. So during the COVID times, this was obviously approved by FDA, but it was mostly used in the developed countries because I think the cost is still too high. So now that it has been acquired by Sherlock, so they are working to see how they can probably integrate it with the CRISPR platform, and they're also trying to see how they can bring down the price and maybe come up with some sort of an access pricing where they're able to sell this to resource-constrained settings and LMICs at a far lower price than it would be available to the high-income countries. So we were talking in the session just before that, Joseph and Charles, they were talking about how the availability of a rapid diagnostic test for HAT was able to revolutionize access to diagnosis for a disease as deadly as HAT. And I think we've all experienced the rapid diagnostics tests in some form or the other. There has been the earliest forms, the urine pregnancy test, and the malaria tests. And during COVID, we saw how the rapid diagnostic test was a game changer in terms of bringing diagnosis as close to the patient, in fact democratizing access to diagnostics. But I think there has been one constant challenge about the RDTs in terms of their performance not being as good as the PCR-based tests. But nevertheless, I think both for, and this goes for all of these sort of point-of-care technologies as well. They're still based on the isothermal amplification methods, which are, obviously, less accurate, and the performance is a little bit tricky as far as the real-time PCR is concerned. But there are still, lots of use cases which clearly underline the need for these technologies in order to increase access to diagnostics. So solving for this particular, and as you know, during COVID, self-tests became available in a lot of countries. And we were able to perform the tests in the comfort of our homes, truly empowering the patients. But again, in a lot of these tests, it was often difficult to interpret the tests. Sometimes there would be a faint line, and you would not really be clear whether it is a positive or a negative. And specifically for a disease like COVID, where you need to isolate yourself, COVID, you can't really be in a doubt. So how do you solve for this conundrum? And this is where I think there has been off late a lot of into these so-called RDT readers. So this is a very small device, cost a couple of and there's a lot of work right now in to reduce the cost of this, so that once you put the RDT in the hands of a community healthcare worker or nurse at a primary healthcare center, they can be pretty sure in terms of the result that in terms of and on this you really have. So once you stick it to designated time,
it will give you a read in terms of positive or negative. So this is also, by the way, a connected device, which means that you can connect this to a laptop or a desktop and have the data transmitted to the patients or to other healthcare facilities. For example, if it is at a peripheral healthcare setting and the physician is not available, the diagnostic test result will be sent easily to the physician and the patient will access care. Moving on a little bit further, can anyone take a guess, and not the can anyone guess what this shiny new device is? It certainly looks like one. Anyone? Oh. Okay, so my friend Davy says it's benign. So this is indeed so who would have thought that complex technologies, large platforms, centralized laboratories. So who would have thought that sequencing would become available on a device as small as this? So let me
open this. So this is how it really looks, in terms of a sequencing reaction. So this comes from a company called Oxford Nanopore, and as you rightly said, this is known as the MinION, or the Minion, so to say. So this device has now been trialed by FIND through one of our Unitaid-supported projects where we sort of evaluated this for the clinical diagnosis of drug-resistant TB. And obviously great results. And this, along with a lot of the other technologies, the results were shared with WHO, who earlier this year, they came up with a recommendation around the use of sequencing for clinical diagnosis, which I think is a sort of a game changer. Because when you compare sequencing with molecular diagnostics, it is relatively easier to have targets on on sequences as compared to adding a drug target to, let's say, a gene expert or a TrueNat or to an M10 here. And it allows you to obviously, sequence the genome, as quickly as possible. And again, this is something which can be connected through a USB to a desktop or a laptop, and you can do data analysis. As we all know, bioinformatics is pretty critical when you're reading, sequencing reactions. So the other good thing about it is that it can read single molecules of DNA and RNA, and can also read large sequences. So this is another one. As far as point-of-care diagnostics is concerned. So moving a little bit from diagnostics to a relatively neglected area of again diagnostics, that is imaging-based technologies. So we know, for example, X-rays have been available for years, but then they have not been used so well as far as disease elimination or disease control is concerned. X-rays, as we know, have a lot of role to play in terms of diagnosis of TB. Or at least screening for TB. And one of the challenges around technologies like X-ray machines, and even though they are now digitized, has been that they are large platforms, and you necessarily need to install them in clinical settings or hospital settings. But all that is changing very rapidly now, and some of you may already be aware that there is a range of new technology which is now available and linked to artificial intelligence and computer-aided diagnosis, which means so one of the big bottlenecks around adoption of imaging-based technologies has been the lack of qualified radiologists or radiographers when we talk of LMEX. Right, so which makes it particularly difficult to read the X-rays, and that is now changing as computer-aided diagnosis and AI-based CAD is becoming more and more available, which means that basically once you take an image, it will compare it against a database it has and will give you a result, which can then be sort of confirmed and used for patient management. So this device here is it's not an X-ray, it is a USG. It's known as the Butterfly. And it is a USG probe, which can be used for chest and abdomen scans. And this is something which you can very easily put into the hands of a nurse or a community healthcare workers. It is battery operated. And the best part is that it is linked to AI, which means that the scans can be read automatically through that AI-based software, and the diagnosis can be provided to the patient. So another, there is obviously, when we talk about X-rays, there are new handheld X-rays which are now available. The only challenge there is the cost. The X-ray technology that is available in the handheld form is still super expensive. It is almost like more than $40,000 or $50,000, which makes it particularly hard to install in LMIC settings. So there's a lot of work that is going on, working with the manufacturers, including AdFine, to see how we can bring the pricing down and make the technology more accessible. So that's it from my side as far as the technology showcase is concerned. So I'm happy to take any questions, and as I said, once you're having dinner, please feel free to walk up to the table, touch and feel. And as they have this sign in the shops, anything that is broken is considered sold. So please be careful. These are fragile devices.
I think that my question was just with regards to issues of quality and calibration. Seeing that they're very mobile, I'm just wondering, like in a rural setting in Zambia, you probably have to travel very far distances. There's a lot of bumpiness and whatnot. Do you still require the same tedious calibration that you'd require, let's say, for a bimural PCR machine for it to get set up and running?
Yeah. So great question, and obviously that is something which needs to be thought of and catered for. So the technologies are fairly robust, in terms of people being able to carry them. Obviously, there are limited use cases so far, and I think this technology has mostly so far been used for COVID-19. But as it becomes more broadly available with a broader test menu, I think these are important questions to consider, specifically for point-of-care platforms, that you not only want to make sure that they are calibrated, you also want to make sure that there is external quality control or quality control available so that you're sure of the results that you're churning out. So yeah, definitely questions to consider as we move forward with these POC tech.
Hi, thank you very much for all this exciting technology and sharing. I have a question regarding, besides the technology, like the availability of technology, I think what are important for feasibility is to think about if there are HR capacity that can be trained in the community or point of care settings, if the samples are easy enough for them to collect. So I want to get more point of view from you about how do you foresee this opportunity to be implemented at the point of care or even
So great question, and as I said, I think these technologies have been designed keeping in mind the fact that they can be as close to the patients as possible, which means that they're easy to use and doesn't necessarily need a trained laboratory technician to be able to operate them. They can be operated, by, for example, this device. It was for home testing, and again, these devices can be by
understanding of how robust these technologies are once we start standardizing them.
For the MinION, what is the cost per, what do we call it, test per run, per sequence? I mean, if you want to analyze one sample, what's it going to cost?
Probably varies from sample to sample. My understanding is that we're trying to get them to less than $20 a test. Yeah, that's the conversation which is ongoing. Yeah.
Optimistic.
I'm not the one who's negotiating, but hopefully, I think this policy guidance from WHO, specifically for TB, I think it has instilled a lot of hope. And as we know that a lot of countries built a lot of sequencing infrastructure during the pandemic, and they're really looking at ways and means of how this technology can be utilized. For example, we had this project from Unitaid, that is the second treat, which has now received a costed extension, and we are now going to be working in 2 countries to see how we can help the countries to sort of operationalize these technologies for clinical diagnosis of drugs and TB. Yeah, but it's a great question, and pricing always is a tricky one to manage whenever you're talking about sequencing, even if you get it to a level of simplicity that we see for MinION.
Do you have some vision towards the future there? I mean, because $20 now, but do people see this coming down significantly?
I think it'll again depend upon the use and the volumes. We saw during the early days of HIV that the CD4 technology was frightfully expensive. I know I worked for BD before I joined FIND, and they were selling tests at like $35 a test. And then, there were pricing agreements which came in, and the test price came down to as low as $5. And the volumes just went through the roof. So the companies were still making a lot of money. I can say that for BD, we were probably making 65% gross profit before, but even after bringing it down, we were still making a decent amount of money. So it'll eventually, I think, boil down to volumes and economies as far as manufacturing, etc., is concerned. Yeah. So.
So I just wanted to follow up on that. So in your contracts with the R&D, entities that you're supporting, is that something that you build into, the contract to say, that the price for the test should be regulated by these factors? Once the volumes pick up, then, the price should go down, and, that's also linked to the cost of production, So, I mean, how do you frame that? I know it's very difficult to then have a ballpark figure to say this is what you charge, But yeah, what is the framework that you work on in terms of pricing?
Yeah, happy to take that question. And I mean, if you go on the FIND website, we've already negotiated prices, and this has been going on for a while, even for CEFED or for TrueNat. And initially, they used to be called as the FIND access price, and these are essentially ex-works prices, which means that there will be additional levies on top of that, once they are shipped into the countries. But I think the way we work with the manufacturers is that, one, I think they would, and this was, specifically true when we were working with these manufacturers during the pandemic, is that they would reserve volumes for the low and middle income countries, and then they would make the price of the tests available at a certain price. So, for example, for the TB technologies that we have negotiated pricing for, and these prices are available to public sector entities. These prices are available to high diseases. They're specifically applicable to the high disease burden settings. And so ultimately the goal is to have a volume-based pricing on a sliding scale. I know there were difficult conversations with CEFED because originally they were designed to be volume-based pricings, but even when they hit the volume, I think it was very hard for anyone to get them to climb down. I think now there has been, some movement in terms of them having to drop the price, probably because TrueNat took that leap and there was some pressure on them. So, but yeah, I think to your question, yes, I think that's the idea, to sort of build in a volume-based scale and reserve volumes and pricing for LMICs and high disease burden settings. Okay, great.
Okay, thank you very much, Sanjay. Let's give him a round of applause. Okay, we have come to the last conversation of the night. I'd like to call upon Professor Claude Movunyi from the Rwanda Biomedical Center, the Director General, to come onto the stage. And Dr. Richard Mihingo, Director COVID-19 Vaccine Delivery from Gavi, the Vaccine Alliance, and Mr. Tapiwa Kujinga from the Diagnostics Equity Consortium. And I will be joining them on stage to moderate the discussion on the WHA resolution, diagnostic resolution of May 2023. Does everyone have a microphone? We're going to be discussing what this means for Africa. Gentlemen, as you take the mic, I'm going to request that you introduce yourself and give 1 or 2 sentences about who you are, and then answer the question that I'm going to pose to you. But maybe as a reminder of what this is about, and as a perfect segue from Sanjay's discussion of the WHA diagnostic resolution, which was adopted in May this year. Just to remind everyone that Africa played a very critical role in getting to that point, supported by a number of other member states that are outside of Africa. And it is said that it's doubtful that without the role that Africa played, whether we would be talking about this today. And particularly Swaziland was one of the leading, Eswatini was one of the leading countries in this endeavor. So now it is up to us to make sure that we move forward and we action this, and we don't go back to where we were before. The resolution lays out 15 recommendations to build strong, resilient diagnostic platforms and health systems by addressing barriers to equitable access, high costs, poor quality, and insufficient training. And it emphasizes that the resolution must be led by countries themselves. Therefore, country ownership is essential for it to be successful. As FIND, we encourage and support all member states to implement the resolution. As part of this
we are supporting and launching a call for commitments from all stakeholders across the global health community to support the implementation of the resolution, which was adopted in May this year.
And because making a commitment is an opportunity for any organization, including governments, technical agencies, NGOs, private sector, and others, to share their commitment in support of the goals of the resolution. The commitments that will be shared will be put on an open public platform, which will be hosted by FIND. While the commitments themselves will be non-binding, the information that will be submitted will be used to track progress on the 15 recommendations that were made within the resolution. So, in order to do this, FIND has set up today, late afternoon today, set up an online submission portal
where all stakeholders can submit their commitment. It should be showing, no? Okay, it is supposed to be displaying on the board there. I'm not sure what happened, but it is, the address is dxcommitments@finddx.org. We're going to send this through for everyone to see. You're welcome to send your commitments there. And then at the
WHA next year in 2024, FIND will be presenting a commitment tracker, which will track progress against all these 15 commitments that would have been made, which would be a very positive task that will be provided for everyone to see, so that this is not just talk, but there's actually action behind the resolution. So tonight I have key stakeholders and partners of FIND who are going to share with us some of the experience and some of the work that has happened even before the resolution, and some of it after the resolution, that demonstrates commitment to honoring and actioning the resolution. So I will start with Mr. Tabiwa, who will talk to us briefly about what the diagnostic resolution means, especially to communities, and what commitments are being considered moving forward. So please start with introducing yourself and then answer.
Thank you. So my name is Davy, and I'm the director of the Diagnostic Dinner. So the Diagnostics Dinner is a consortium between MSS, between and the Economic Center of University. I think also the people in this room know Cheryl sitting at the top. Sitting at the and so we started working on this, and the diagnostics resolution really gave impetus to the work that we are doing currently. But before I go on, I want to pay tribute to FIND for the work that you did, ensuring that the diagnostics resolution goes through. I think there was a lot of work which FIND did behind the scenes, which may not be acknowledged, but which I want to acknowledge right now, especially the technical support which was given to expertise which was leading the process.
Shall I give it a couple of more minutes, or shall I pass the mic?
Okay, for now, let's pass the mic.
Sure.
Yeah.
Thank you.
Yeah, good evening, actually, and sorry to join late. I was engaged in other different session at the MCC. So thank you, first of all, for the invitation extended to Gavi. My name is Dr. Richard Mihigo. I'm the Director of Country Program, working not only on the COVID delivery, but leading our new ambitious work on pandemic preparedness and the response. So to respond to your question, let me first start by saying that our interaction and collaboration we find is not new, something that we've started since 2018 when WHO launched the, as you know, the I strategy, the Eliminating Yellow Fever Epidemics program in the African region. So we really partnered together to develop a rapid test for yellow fever, and maybe I can come back to that later on. And we've expanded that cooperation. We have a MOU that we've signed with FIND, where we're providing some funding to support your work. And we are very much looking forward to the implementation of this, I think, historic WHO recommendation. We're very much happy to see the final endorsement of that resolution, and Gavi will be looking forward to working with you, to supporting the countries in the implementation of these key actions that have been highlighted in that resolution. So thank you.
Thank you very much. First of all, I think I would like also to thank FIND to organizing this session, but also to invite Rwanda to be part of this discussion. My name is Claude Muvunyi. I'm the Director General for Rwanda Biomedical Center. But again, this is really something that's very important to me because I come from the background of clinical microbiology, so I'm really in the space of diagnostic. So that's why really I'm happy to be here to this night to really make sure that we discuss at least these resolutions. For those of you who are not familiar with Rwanda Biomedical Center, Rwanda Biomedical Center is the equivalent of National Public Health Institute. But for us, it's a little bit different because we have that institution as the main implementing agency for the Ministry of Health. So we implement all the programs. If you can say, for example, we ensure that all our essential public health functions are really existing in our health systems. And we do that by really strengthening the system. We ensure that there is a workforce which is available within the system, but also dealing with all other programs like HIV, malaria, TB, maternal and child health. But on top of that also, the National Reference Lab is under the Rwanda Biomedical Center. So Rwanda Biomedical Center was 10 years ago. Those divisions were working in vertical ways, in silos under Ministry of Health. But we thought that, again, it would be very good to integrate all those programs. And the integration is something I think is the core mandate of what FIND is trying to really ensure when it comes to diagnostic. So for Rwanda Biomedical Center, it's really very easy to integrate, for example, programs like malaria, HIV, and also bring National Reference Lab to really coordinate all the interventions of diagnostics. And this is also a way of really having one governance, but also integrating the financing of really how do we finance diagnostic to support programs to get, for example, people, the community being diagnosed for HIV, but also diagnosed for other diseases. So this is one of the strengths for Rwanda Biomedical Center. So as I come today, I think for Rwanda Biomedical Center, we know all that diagnostic is really very important at the core and the backbone for any healthcare system. And I've seen that during the last COVID-19, where I think, for me, I was very happy because this is something I had in my heart like 1 decade or 2 decades ago, when I think we're diagnostic people were very neglected, and diagnostic, I think, was not even discussed at the table. I remember, I can give an example. For example, when I had to implement, to really allocate resources, but also have some interventions around programs. If, for example, there was an activities where we had to allocate cars to take, for example, staff to go to the field and do supervisions, the labs staff were always at the last on the list. So I think it was already neglected. But thanks to, I can say thanks to some of the pandemic now, I think not everyone is now interested to really understand very well, do we have diagnostic capacity to detect early, or to really provide early detection of any outbreaks. We have seen the example of COVID-19. For our regions, again, Ebola was there. So we had no capacity for diagnostic in terms of the tools, the equipment, but the staff who were trained. So I think from that time, I think I'm glad to see that even politicians now are really concerned. If they hear some case about, for example, yesterday I think we heard about a flu pandemic, new flu strain in the USA. I received a call from, for example, my minister saying, are we ready for this? So I think this is something I think very good today, and it's really, these resolutions comes at the right time, which I think Rwanda is going to support. And I'm glad to say here, for example, to link this resolution of today with the work that we have been doing with FIND. I think FIND has been very instrumental in our intervention to make sure that we make accessible diagnostic. And we have had some good projects with FIND in the COVID-19 where we're able to really implement simple tests like lateral flow antigen, be done by community workers, and really to the last mile in the households where community workers would be able to use diagnostic, but also linking the digitalization of this system where from the central level we were able to really know the case which are diagnosed but also treated, but also providing some space for this. And today we are now expanding these lessons from COVID-19 now to other diagnoses. As of today, we are working again with FIND to make sure that we apply the same technology, the same innovations, using our community talkers, for example, to apply the clinical diagnostic in terms of really identifying the suspects within the community, but also administrating the testing, and again, really reducing the time and the travel for suspected TB patient to come to the facility. So those are the areas probably I think is really an evidence that we have been working with FIND. And today, even before that resolution, of course, I think today, resolutions comes at the right time. We hope to really continue to work with FIND, but other partners in really making sure that we really provide equitable access to diagnostic where it's needed. So I can stop here. Maybe elaborate later on how are we going to really continue to work together with FIND throughout this, implementing this diagnostic resolution. Thank you.
Maybe coming back to you again, Tapiwa, one of the key focal areas in the resolution is about making sure that everyone who needs a test, wherever they are and whenever they need one, they are able to access one. What does that mean for the person who is out there in the community? What sort of commitment considerations should we be thinking about if we want to make that a reality?
Thank you, Ntombi. So when you look at the diagnostics resolution, it's got 15 commitments, as you said. And it's, when I look at it, it's a generic document. It's, each resolution speaks to the rest of the resolutions. And one of the resolutions is that there should be increased research and development in diagnostics. And I think, what we, Sanjay was presenting is part of the process, because you cannot have accessibility without availability. And you cannot also talk about accessibility without having affordability. And that's with the research and development process. And then the resolution also talks about each country having diagnostics strategies. How do you get the diagnostic to the last person in the remotest village? And then at the same time, it also talks about having essential diagnostics lists, which means the country must prioritize the in vitro diagnostics, which must be especially at the public health care level. So I'm just giving that background because if people who need diagnostics are able to get them, it must be part of the process. It must be part of a chain. So I think what countries need to do is to ensure that they put the building blocks for the accessibility and availability of diagnostics at the ground level. And also countries must make sure that they build sustainable systems. And this is one challenge in Africa. We tend to be reactive. Once, a pandemic comes, we pour in resources. Once it goes away, then the systems are destroyed, but that's not sustainable. So we need to ensure that our health systems create sustainable systems for ensuring that diagnostics are available whenever they are needed and wherever they are needed, by having diagnostics strategies, essential drugs diagnostics lists, and to ensure that the systems are able to support all that. Thank you.
All right. Thank you, CPHIA. And then coming back to Dr. Mahingo, we've had a lot in the past 2 days of this conference around how much Africa needs to develop our own vaccines and how much we need to strengthen clinical trials in relation to the commitment that we need to make around the diagnostic resolution and related to vaccine development. What is the one critical commitment that you would say we need to start considering?
Well, maybe I will respond in two ways. The first one, I think there is a lot of movement that is currently being done in the area of vaccine research and development, including what has been discussed the last 2 days, local manufacturing of vaccine as a consequence of what we went through during the COVID-19 pandemic. At Gavi, for instance, we are preparing a financial instrument called the African Vaccine Manufacturing Accelerator, which will be, we're going to discuss that next week in Ghana to our board meeting, a 1 billion financial instrument that will help local manufacturing on the African continent actually to produce vaccine, and we can buy those vaccines from local producers. But I want a bit to shift from that and to discuss and then to build on what you have said. When we looked at the diagnostic situation, and we in the immunization space, for instance, if we take a disease like yellow fever, up to not long, the whole African continent had only one laboratory, Institut Pasteur Dakar, that were able to do confirmation of yellow fever cases. So you can imagine that for suspected cases that were detected in any cases, in any country, all the sample had to be sent to Dakar for confirmation. And by the time you detect a case in the community, the confirmation, sometimes it was taking 2, 3, 6 months of confirmation. What we did, for instance, with through the eye and find, was how can we get a rapid test for confirming case of yellow fever, so that we can at least target our intervention in terms of a vaccination campaign.
Because as you know, all cases, when we looked at a clinical definition for yellow fever, for instance, was like, okay, fever, jaundice equal yellow fever. and actually countries starting to mount mass vaccination campaign, requesting vaccine to Gavi, a lot of resources that will be diverted to conduct a large campaign. But now we've now 3 tests actually that we have developed through our collaboration, an ELISA test, of course, RDT and molecular test. These tests went through all the process, validation, and now even we are launching them at scale. We have opened a funding window where countries can access funding to procure those tests. And we have seen the difference that it has made on a public health perspective in many countries. In Mali, and I believe in Ghana, actually 2 campaigns were not conducted because actually with the detection of using the rapid diagnostic test, some of these clinical cases were not yellow fever in reality. So it has saved time, saved resources, and etc. On contrary, where we had a rapid detection of cases in the community, we have seen, for instance, in Burkina Faso, where we can mount a rapid campaign that will actually circumvent the spread of the outbreak. So this is where we are seeing the advantage of the work that we are doing in having quick tests, rapid tests that can be deployed in the community for confirmation of the cases, that we can take a public health decision based on that. So we are embarking now on cholera for the same thing, where there are 3 tests, rapid diagnostic tests have been gone through the R&D process, the validation process, and we are seeing how we can actually expand like we did for yellow fever. We are doing the same for meningococcus. We're trying to do rubella, though rubella there's some problem, measles, and etc. So this is where we are seeing the impact of the work that we are talking about here on the country programs, on how we can save lives, because this is what it is. We can reduce the magnitude of outbreaks when cases are detected rapidly. Campaign or strategy can be conducted efficiently in a timely manner. And this is why we see this resolution making a difference. But the resolution by itself is not going to make things done. I think it's a starting point. It's a starting point, and the issue that you raise around having a tracking of commitment from countries. We, for instance, we are committed to continue to fund area related to vaccine preventable disease tests, but there are a much more broader spectrum that we need to bring additional in that space to make sure that it's not a fancy things. It's become a reality in the day-to-day life of healthcare workers living in a remote area where they can have confirmation of it.
Thank you very much.
I think I think the resolution is a good thing, and you're happy that this resolution is coming at the right time where there is political will. There is also now commitment for all the governments to make sure that we have tools available when we need them and accessible to the populations. I think there are a lot of things that now is going to really be done to really accompany these resolutions. And I hope that for us was around, for example, building on that political mix. We have really some strong, meaningful partnership, which I think is going to really making use of those tools which are available. But now, how are we effectively use those tools? So I think those are the areas probably would be the focus if we continue to work with different partners to make sure that we have those evidence data that could really allow us to adjust those interventions based on those tools which are available, but also supporting the pandemic early detections and also improving the management of clinical patients. So I think this is really something I'm glad to continue to support, and also all the countries I think is going to be beyond this resolution.
much. Are there any questions from the floor?
But I just wanted us to comment on, there's a huge dichotomy between diagnostics for clinical care versus diagnostics for surveillance and public health. And I think that's a bridge that, as we go about implementing the resolution, that as a community we address. I think one of the other real challenges is the data, and data from, from reaching, whether it's clinical care, and seeing how that data can be available to, to the public health institutes. The other is private sector, and as we, very critical, and maybe a comment would be useful in terms of how we can derive insights from private sector diagnostics, because in many countries, most people access care in the private sector and not in the public sector. So there's a huge data side there that we need to think about.
Very good point there, Emmanuel. I think it also fits in well with the summary of some of the signed commitments across the 15 recommendations, which include working with countries to establish national diagnostic strategies and strengthening capacity of care providers in communities and in primary care settings, and investing in local research and development and manufacturing of diagnostics, amongst many others that cover all 15 of the diagnostic resolution recommendations. At this point, I would like, there's another question? Okay.
Thank you very much for the interesting discussion. I'm sitting here thinking implementation of 15 resolutions as a laboratory directorate could be rather confusing and too much. Is there a guideline on a step-by-step process of how laboratory directors can implement all these 15 resolutions? Or the resolution should be implemented as they are?
I will attempt to answer the question, but I would leave it to the diagnostics experts to answer it. But my question to you is, how do you eat an elephant? Piecemeal by piecemeal. So, but the important thing is that we have the diagnostic resolution now. So what are the next steps? So the first step, as suggested in the discussions today, is making commitment. What is it that we want to do now that we have this resolved and we are clear on what needs to be done? What are we committing to do to make sure that we achieve this? And once we have made those commitments, we need to be able to track that we are going in the right direction. Are these commitments that we have made going to lead us to achieve the goals that we intended in the first place? So I don't think that it will be the laboratory manager's responsibility to ensure that all 15 of the recommendations are being achieved. It's going to be a process like in most programs where you need to countries will need to develop strategies, adopt policies, develop guidelines, and implementation plans. I don't know if anyone else wants to answer the question.
Yeah, I think just to build on what you said, you are absolutely right. I think all the recommendations are not meant for the laboratory directors level. There is obviously stuff that politicians need to do, policymakers need to do. There is an essential diagnostic list, the national lab strategic planning, and there are specific recommendations for innovators and manufacturers to make these diagnostic technologies available. So it is obviously, something for everyone in that resolution. But obviously, I think the bottom line here is that people need to come together in order to make sure the countries who are supporting this are also able to sort of take the resolutions forward and enable the availability and accessibility of diagnostics as, Ntombi just said in terms of the NLP.
You asked who we are waiting for the next person to ask. Can I just also take a step with this one? Yes. So we as the DEC, we realized together with FIND, we also realized the challenge. In Africa, many times when resolutions are passed, the next thing is they are put on the shelf and nothing happens. And we've seen that, many, many times. But as a DEC and FIND, we realized we need to move forward. So, on the sidelines of the UNCA this year, we had a civil society session where, we had people from all over the world gathering and coming up with a call to action. What needs to be done, right? Step by step. So with the call to action, where we are talking to governments, we are talking to civil society, organizations, and we are talking to pharmaceutical manufacturers in terms of what we want to see them doing and what we also commit ourselves as civil society to do. We have got copies of the call to action right at the back where the water is. You can take a copy, and I will encourage everybody to take a copy. We've started some, a mailing list, and we want to be talking in terms of, advocacy steps, in terms of, pushing issues forward and getting things done, so that at least we can hold our governments accountable, we can hold ourselves accountable, we can hold pharmaceutical companies accountable, and make sure that the resolutions are actually implemented. Thank you.
Well, I just wanted to nuance a bit. Whereas in Africa, many of these resolutions stay on the shelf. I think this is not a situation that's proper to Africa. I think it depends on the way the constituent party take these things forward. I don't think that even though the resolution was written by Swatini, etc., this is a WTO resolution. And we should not say that because it's Africa will put it on the shelves. I think it's a global resolution. Now, I think what's more critical, I think it's what you have highlighted. There should be a call to action that's followed that. There should be really a deliberate effort to make sure that the different area, depending on the stakeholders that are involved in different pieces of the resolution, takes their own responsibility. It's a very powerful political instrument to rally the support, but it's not enough. I think call for action, the different stakeholders all needs to come together to make sure that it becomes a reality in the life of the director of the laboratory on this day-to-day work.
Thank you very much for the statement. Are there any other questions? I don't see any. I'd like to take this opportunity to thank my guest speakers. It's been really great. I wish we had more time to talk a little bit more. This is the most topical issue at the moment. I would like to ask my colleague from behind, and thanks my two colleagues, and ask them to please return to your seats. And could you please give them a round of applause? Okay, having been talking about the diagnostic resolution, it is. We have the pleasure today of having an opportunity to meet in person our key partner from Rwanda, who is arguably, I'm very new at FIND, I could be wrong, our first partner, key partner, post the announcement of the WHA diagnostic resolution that we have signed a firm memorandum of understanding with, which is very appropriate to the work that needs to be done around implementing the diagnostic resolution. So FIND signs an MOU with Rwanda Biometric
developing tools and diagnostic systems to enhance equitable testing in primary healthcare and digital transformation in the country. So this is an opportune moment. I would like our executive, one of our executive directors from FIND and the Director General from the Rwanda Biomedical Center to please stand for a photo opportunity in front of our other friends of FIND as a sign of continuing partnership and also to demonstrate how FIND is serious about strengthening diagnostics and how important it is for FIND to work with all partners. So with everyone in the room, we would like to work towards strengthening laboratory systems. Why is the light going out?
No, it's fine for the picture. Thank you.
Thank you. A round of applause. Oh, the Rwandan colleagues.
So for the uninitiated, just to let everyone know that this MOU was signed some time back. I just wanted to take this opportunity, since the Director General is here along with his colleagues, to make it, share it with us, with our friends and partners.
Sandy's feeling lonely, so
yes, it is.
And thank you everyone for indulging us in our show. And dinner is served. Have a wonderful evening. You've been a great audience.
Cut the audio.
So I think before you move for dinner, we also wanted to make an announcement. We are having a breakfast panel tomorrow. It's early, 7 a.m., but we'll obviously serve breakfast. So this is a panel which we are jointly hosting with Unity, and it is around action towards creating sustainable markets for diagnostic innovation. So it will be great to have all of you there. Look forward to seeing you again tomorrow.
If I can add one more, on a totally different topic, if you're interested, Thursday morning, the American Society of Tropical Medicine and the CDC are hosting a session on changing architecture of outbreak response. I'd love to see you there as well. Thursday at 7.
Will you be so interested?